Good morning, everyone. I'm Dr. Gayathri, Assistant Professor in the Department of Pediatrics. And today we are going to see a topic, a very common topic, which is called as rickets. So you would already know what rickets is, what is its association. So as you would have all read from your undergraduate days or even your last school days, rickets is something, has got something to do with the vitamin D deficiency, isn't it? So uh, we are going to go into every aspect relating to rickets. So in today's class, we will be covering the following topics. First, regarding vitamin D and its metabolism. What are the sources and the recommended daily allowance? How do you classify rickets? Whether there is only one type or there are many more? And clinical manifestations of rickets. And how do you manage nutritional rickets as well as refractory rickets? Coming to the metabolism of rickets, of vitamin D. So, vitamin D is obtained, one of the most common sources is sunlight, isn't it? So, sunlight and mainly from the UVB rays. Okay, the ultraviolet B rays are the main source of vitamin D. And the wavelength of this ultraviolet rays is 290 to 350 nanometers. So, in our body, we already have something called as 7-dehydrocholesterol on the skin. So, giving this proper UVB or sun exposure and also from dietary sources, it becomes vitamin D in the crude form. This goes to the liver and is acted upon by the enzyme vitamin D 25 hydroxylase to form 25 hydroxy vitamin D. Then it goes to the kidney, and here you have another one enzyme. So already 25 is assessed, 25 hydroxy vitamin D, 1 alpha hydroxylase. So when the first one was plain vitamin D, you added a 25 hydroxylase enzyme, it became 25 hydroxy vitamin D. Now you have 25 hydroxy vitamin D, 1 alpha hydroxylase. Now it becomes 1,25 dihydroxy vitamin D. This is in the kidney. From here it goes to the target tissues, which is the kidney, intestine, bone, parathyroid glands, respectively, to cause its biological effects. And here you have a vitamin D receptor present at these sites, which makes sure vitamin D goes and causes its biological effects. Another pictorial depiction of the same, it is in a more pictorial way for you to understand better. So again, we have 70-hydrocholesterol, which is pre-vitamin D, acted on the sunlight and the dietary sources to become vitamin D, or directly vitamin D through food. In the liver, you have 25 hydroxylase to become 25 hydroxy vitamin D. And then in the kidney, you have 1 alpha hydroxylase to become 1,25 hydroxy vitamin D. So here, besides this, you have two other enzymes, 24 hydroxylase. They have become 24-25 hydroxy vitamin D or 1,24-25 hydroxy vitamin D. These are separate things. But our main pathway you should know is this 25 hydroxy vitamin D and 1,25 hydroxy vitamin D, from which it goes to the effector tissues. One is intestine, where it causes calcium reabsorption. Next to the bone, where it was fibroblast growth factor increase and again calcium reabsorption. And when enough is there, it causes a negative feedback. You can see the negative arrows here. And another thing, if in case calcium levels is already low and all, this parathormone will be stimulated and it secretes parathyroid. Parathyroid gland is able to secrete parathormone, which will make sure this 1 alpha hydroxylase is activated. So when you have enough of 1 alpha hydroxylase, enough serum calcium, because by absorption, this parathormone levels usually decrease. What are the sources? Dietary sources. Okay. So egg yolk is a very good source of vitamin D. Fish and fish oils. For vegetarians, plant sources are mushroom and paneer. And the sunlight, UVB 290 to 350. That is what we saw when animal with the bandwidth. And generally, timing is preferred as per Indian Academy of Pediatrics guidelines is between 11 a.m. to 3 p.m. So the vitamin D rich foods again here, see cod liver oil or fish liver oil, mushrooms, paneer, raw milk, egg yolk, then fish items. What is the recommended daily allowance? For infants up to 1 year, infancy that is up to 1 year of age, the recommended daily allowance per day is 400 international units. Above 1 year, it is 600 international units. Pregnancy lactation again, it is 600 international units per day. That is why calcium with vitamin D and all is taken during pregnancy and lactation time. And breast milk contains only 30 to 40 international units per 1 liter. So babies will not be actually drinking liters of breast milk per day, isn't it? They have only a certain capacity. So that is why to make sure the required vitamin D is there and for these infants, you only provocatively give vitamin D supplementation for all babies till 1 year of age. Okay, before they take the full family pot food and diet, they will be given daily supplementation of 400 international units per day of vitamin D. So how do we classify vitamin D? So already from the overview which I gave you, nutritional rickets and refractory rickets, two types that you would have seen. So in this itself, there are different types. Okay, one is another type which is called as calcipenic, another one is phosphopenic. The calcium is deficient and phosphorus is deficient. Calcipenic rickets itself is having nutritional calcipenic rickets, mainly because of vitamin D deficiency. This vitamin D is important for calcium absorption. So it can either maternal vitamin D or nutritional vitamin D deficiency per se. Skin synthesis of vitamin D is reduced because of sunlight deprivation or sunscreen use over or an increased skin pigmentation or malabsorption problems like celiac disease, hepatobiliary or inflammatory bowel disease, or drugs like anticonvulsants or glucocorticoids in excess, and obesity. Or it can be a nutritional calcium deficiency alone per se. The non-nutritional causes where calcipenic rickets also occurs are inborn errors of vitamin D metabolism, where there is deficiency of 1-alpha hydroxylase in the where kidney, PDDR type 1, and loss of function mutation of vitamin D receptor. I told you after 1-alpha hydroxylase is there, you have vitamin D receptor which helps to act on the target tissue. So there, that is yours, just vitamin D dependent rickets type 2, or a distal renal tubular acidosis, RTA. Phosphatemic rickets is mainly more of a kidney defect per se. It can be a renal tubular disorder where there is increased phosphate wasting, FGF23 dependent. Hereditary hypophosphatemic rickets, which is X-linked dominant, autosomal dominant, or autosomal recessive. Acquired due to maybe tumor-induced osteomalacia, McQueen-Albright syndrome. And either otherwise, it is a primary defect in renal phosphate absorption itself. Okay, that can be a proximal tubular dysfunction. Fanconi syndrome, stenosis, tyrosinemia, galactosemia, IEMs are there. Or a hereditary hypophosphatemic rickets with hypercalciuria. Okay. Or it can be a dietary phosphate deficiency, like we have a dietary calcium deficiency, which will be there usually when people take over antacids, aluminum containing, or in times of prematurity. So, this is how these are the types of rickets and all we should see. So, based on our history, signs, symptoms, and signs, we should come to a conclusion. So, what in general, what are the symptoms which we get? One, in infants in the younger age, especially less than 6 months, when vitamin D is associated with hypocalcemia, it will usually, if it goes to that extent, it will present as hypocalcemic seizures. Okay, which is one of the causes, one of the differential diagnosis of seizures. Checking for hypocalcemia is a common thing which we do. And infants and babies present with seizures, especially in the neonatal period and for 6 months. In older children, as they go, since we know this vitamin D going is important for calcium absorption, everything together, isn't it? So, intestine, bones, parathyroid, kidneys, everywhere it is going. So, bones and all that, when it is there, then generally developmental delay is there, especially in postmortem milestones. And over a time, since ossification and all is not happening, and bone maturation is not happening, they lead to skeletal deformities too. In adolescence and adult children, they present with lower limb pains, okay, arthropedal spasms, and sometimes knock knees, knocking together. When the knees knock together, this called as knock knees. So what is arthropedal spasm? That is something when you see, you can see that the children will be having some spasms of the either lower limb or upper limb, and you can check it in your OPD by tying a BP cuff and increasing the pressure about 20 mmHg above the normal SBP and hold it with pulsate. You will see there will be spasms formed on the hand. Okay, so these are the in general signs. Otherwise, the child may also be lethargic, tired. Okay, non-specific symptoms are also available. In the signs, let's start from head to toe. Skull, one of the most important features here is craniotabes, which is an early sign. Here, because not improper mineralization ossification is occurring, bones are still soft like baby skulls. Okay, so that is called as craniotabes. It will be a little soft. Then the frontal part gets bossed in front rather than because of all this. There is positional thing, the frontal bossing occurs, so that appears prominent. Then, and the skull starts becoming like a box shape, and that is called as caput quadratum. You look like it has four corners, and there is delayed closure of the anterior frontal. So that is an very important sign which we look for in all infants who come to us with follow-ups and all. We see whether the AF, which usually closes at 16 to 18 months away. So we see whether the size of AF is big or small, whether it appears to be closing and all that. Teeth, there is delayed teeth eruption. And for those who come, there will be enamel hypoplasia. Coming to the thorax, in the ribs, there is something which is a beaded appearance called as rachitic rosary. And and also the chest will appear like a pigeon chest pectus carinatum. And there may be groove on either lateral side, which is called as a Harrison surface or a Harrison's groove. In the extremities, coming to the arms, wrist widening is a very common feature when you see. So the wrists and hands usually appear the same thing where the wrist will be widened. And in legs, you have something either called as genu varum or genu valgum. So again, in complaints, they will tell you knock knees. So knock knees means both the knees come together. So it looks like a valgum. That knock knees, and another main medical term for knock knees is genu valgum. And when they because and when the knees are spread out together like bow legs, that is called as genu varum. Genu stands for the knee, isn't it? So how I remember is L, the letter L comes in valgum. So when the both knees knock together, the letter L comes, isn't it? When you draw like this, two L's. So that is why knock knees becomes genu valgum and bow legs becomes genu varum. Saber shin deformity. So saber teeth, you have seen it. So it looks sharpened towards the end and blunt, splayed out. So that is one deformity. And since the bones are not ossified and mineralized properly, they are very prone to frequent fractures. So infancy time fractures are called as green stick fractures. And a little prolonged time, again, the bones, when they try to bear the weight of the body, they start bending. So they look like these trees, when they bend in the wind, they look like they are slanted to one side. The limbs also will look that winds were deformity. And ankles will show a phenomenon called as a double malleolus. So again, ligaments and muscles, tone of the muscles decrease, myopathies will come, and ligaments will also appear lax. They'll all adding to these deformities. And spine, if you see, if again, like head showed softening craniotabes, if the spine vertebral softening for more than 2 years, it will also cause kyphoscoliosis. Forward bending is kyphosis and lateral bending is scoliosis. So now we'll see the images of what we have done till now. Let's see whether you will be able to relate to whatever I told you. See, here there's a big skull, which is actually, if you see from top, it look like a box shape. The important thing to note here is a frontal bossing, which I told you. Here, what did I tell you? A beaded appearance in the costochondral junction, which is called as rachitic rosary. Okay. Here, where the image quality is not so good, I hope you can identify the widening of the wrists. Here, when you see the two knees are knocked together, and you can see the L shape which I'm trying to mention, isn't it? So this is genu valgum, and bow legs, which is genu varum. This, what I told you, is the Harrison's groove or Harrison's sulcus, and a pigeon shaped chest. Okay, like this, marinator. And here is one image which is not very clear of the softening of the bones showing a windswept deformity. I have another image also to show you. See, this is another image in the clearer one of a windswept deformity of the lower limbs, and this is the malleolus showing double malleolus. So now we have seen in a theoretical way everything, isn't it? What are the symptoms? What are the signs to look for, isn't it? So now the child is coming to you. So what are the, as a whole, how are you going to approach this case? Okay. One, history properly. So you know all the causes, isn't it? Dietary causes are there. So asking about the dietary intake, what are all the child takes, especially dairy products, milk products, non-vegetarian food like fish, eggs, and all you should ask, and also sun exposure. We told that drugs, anticonvulsants are, or steroids are also, after also drug history. Malabsorption syndromes and chronic renal diseases are all problems we saw. So ask about the chronic renal or liver diseases and malabsorptions. Prematurity, hypophosphatemia we saw. So to, and again, for renal tubular acidosis, we should ask antenatal history of polyhydramnios, algahydramnios, polyuria, polydipsia, and failure to thrive and muscle weakness in children. Parental consanguinity, because there are so many inherited causes also, and similar involvement in siblings. And also ask whether the child has had some other problem for which any calcium or vitamin D had to be taken, or during the initial infancy whether proper supplementation is also given. Examination, obviously, for every child, irrespective of whatever case, anthropometry, weight and height against a specific age is very important. Also, head circumference, the arm circumference for and all is very important. Okay. Upper segmental, lower segment ratio, these things are all to be taken, especially for this case. Look for signs of vitamin deficiency and any deformities in head to toe. Examine the hair, which may be sparse, and again, teeth, delayed dentition, enamel hyperplasia, and all that. Do Trousseau sign, which is seen in carpal pedal spasm. That is the one which I told you by OPD, by tying a BP of 20 mm HT above the SBP and holding it for 10 minutes, you will be able to see spasm. And for VTDR type 2, there are some subtle features like anemia, epidermolysis, and alopecia, which can be seen. Chronic renal disease, since it is a chronic disease, they will definitely have short stature and hypertension. Anemia, microcytic hypertrophic anemia will also be there. With a chronic liver disease, hepatosplenomegaly, edema, and jaundice are also to be looked out for. So you should not think of each one and then do all these things together. Look for any, check the BP for every child, look for pallor, checking anthropometric short sightedness, look for HSM in all the children, look for edema, look for jaundice and all that. And also, since we saw for ligaments and muscles also hypotonia and all that is seen. So you should check the muscle power, and CNS also should be done, even though it is vitamin D. So once you've done all that, baseline investigations which we do for everyone is a serum calcium, serum phosphorus, and alkaline phosphatase. Preferably to rule out liver and renal parts, recreant and albumin. Okay? Preferably all that one should be fasting samples. And if clinically you have any suspicion, make it a full liver and kidney function test. When you think of it, this is going to be a more of a non-nutrition cause because of more of history and physiological and physical examination findings. Now, I think to rule out acidosis, you should do a venous blood gas. And secondary things are 25 drugs vitamin D, 1,25 vitamin D, and PTH. And to rule out all the other phantones and hereditary phosphate deficiencies and RTA, all those, you have to do 20 spot or 24 hours urinary calcium creatinine ratio, and also check for the tubular reabsorption of phosphate. So either so how do you take for the tubular reabsorption of phosphate is you should in the morning fasting time you should take the serum phosphate sample and a urine phosphate sample. And so the excretion of phosphate is taken by urine phosphate into serum creatinine, by serum phosphate into urine creatinine. So these samples are taken. Into 100, you get the excretion of phosphate. So to find out the reabsorption of phosphate, it is a total, uh, it is 100 minus the excretion. So normally it is around 85 to 95%. So besides the blood and urine sampling, radiology is also taken for all cases. What do you take? Depending on the age, you will take an X-ray test or a knee. You look for widening of the growth plate, generalized osteopenia, and the metaphyseal area showing cupping, splaying, and fraying, because metaphyseal growth is never getting over. There's no acidification happening, and so mineralization does not occur. So that part alone, growth plate keeps on widening, widening, widening. That's why you get all this wrist widening and all. And finally, it leads to cupping, playing, and spraying. And renal ultrasound shows nephrocalcinosis. So when coming to some X-rays, so this is a wrist X-ray going on very clear. I hope you can see it is an AP view and lateral view of an 8-year-old boy with rickets. And here you can see this metaphyseal region, which is looking like a flower vase like this, expanded to its lateral with a wide and broad plate. Here again, it is a little more clear, cupping and splaying and fraying is happening. So in this image, there is both a normal and an abnormal one for you to identify the difference more clearly. So here the normal growth plate is around straight and inside bone is mineralized well. Okay, there is no widening of the space, there is no cupping and all form. But here you can see there is cupping and the borders are very irregular. That is why it is called plain, and the ends are splaying is also called. So when you call this refractory rickets, so when you try nutritional causes and it does not respond at all, then you can either call it refractory rickets after 3 months of therapy. Okay, when there is no response. Otherwise, when you have these other causes which come into play, you will know that it is not just a normal nutritional rickets. So when it is a renal refractory rickets or a secondary cause, important investigation that you do is a serum phosphate. The serum phosphate is high. It is always, you can directly label it as coming under a chronic kidney disease, because phosphate excretion comes through the kidney. So it's not happening. So it's generally a kidney problem there. If the phosphate part is normal, then you will consider doing a blood pH, venous blood gas or arterial blood gas. Okay, if you get acidosis, then it is labeled as a renal tubular acidosis and you manage accordingly. So that part is normal. Now we will come to calcium and parathyroid. Okay. So if the calcium is low and parathyroid is high, so that means something is going there. So it is some vitamin D dependent rickets. It is an enzyme problem down there. But if the calcium is normal, parathyroid levels are also normal, then only hypophosphatemia is there, then it is not hypophosphatemic rickets only per se. You have to look for those hereditary causes and all. So when you see again another table to depict these different changes on the blood investigations that we do, whatever investigation we've been talking about. So as I said, most common ones we do are calcium, phosphorus, alkaline phosphatase, 25-hydroxyvitamin E if needed. Others are parathyroid, 1,25-hydroxyvitamin D, urine calcium, urine phosphorus. So if it is a normal nutritional vitamin D deficiency, calcium is low, phosphorus will be low, and alkaline phosphatase will be high. Parathormone will be high because low calcium is making more secretion of parathormone. 25-hydroxyvitamin D that is coming from the liver, that itself is low. Okay, 1,25 can be normal or increase depending on PTH, much as I take. Urine and calcium and phosphorus. Since urine calcium itself, serum calcium itself is low, urine calcium will be low, but urine phosphorus, because PTH is acting on the kidney, and otherwise urine phosphorus will be normal or high. A dietary calcium deficiency will show again same features here, but 25-hydroxyvitamin D can be normal or decreased this way or that way. The only thing where I told you the serum phosphorus is increased is where chronic renal failure. Can you see? This phosphorus arrow is down and everything except this. So it's for example, if you get a serum phosphorus is increased, you can label and rule out that part. So VDDR type 1 and type 2, I told you they are more receptor driven problems. So In type 1, 1,25 vitamin D is not found because there's one alpha hydroxylase defect. Type 2, it is a receptor defect. So this is also normal. Will be high actually. Okay. So 25 will be normal. This will also be high. But still you will have features of vitamin D deficiency by low calcium, low phosphorus, increased alkaline phosphatase and all. When you go to hereditary phosphate problems, everything else will generally be normal. Okay. It is, yeah, here now PTH will be a normal value. So not, it will not be high because there is no calcium deficiency. Here, calcium values are normal. Okay, so that is something which you should note. So now coming to the management. So management wise, first aim is to take care of nutritional rickets management only. So when you have a child with nutritional rickets, hypohidrosis, first we'll see whether the child is having hypocalcemia associated with this. Okay, so if the calcium part is normal or an asymptomatic hypocalcemia, we will check the age. So the age-wise cutoff in management is divided into three parts. One is less than 6 months, 6 months to 1 year, more than 1 year. The less than 6 months, we start management as 2,000 international units per day for 90 days or 3 months, along with 50 to 75 milligram per kg per day, which is maximum of 500 milligram only of oral calcium also. At the same time, child is between 6 months to 1 year, we will give 2,000 international units for 90 days or 30,000 international units once a week for twice a week for 6 weeks or 60,000 international units. No, but 30, sorry, 30,000, it is either 2,000 international units once a day for 90 days or 30,000 international units twice a month for 6 weeks or 60,000 international units once a month for 3 doses alone, along with oral calcium throughout the whole thing at the same dose. More than 1 year, we will give 3,000 international units for 90 days or 60,000 international units twice in a month, once in 2 weeks for 5 doses plus the oral calcium. Okay. So, revising again, less than 6 months, 6 months to 1 year, more than 6 months. Till 1 year, it is 2,000 international units per day for 90 days for both. Plus 50 to 75 milligram of calcium kg per day through the entire course for all the three. Dilemma from since for small children, only this daily dose is taken. When they become more than 6 months to 1 year, we will give a trial of either 30,000 international units once in 2 weeks for 6 doses. Okay, 30 is one number. Once in 2 weeks, 3 to 6. So 6 weeks of dinner. You can remember that number, that's right. Or 60,000 international units once in a month as 3 doses alone. Okay. When the child is more than 1 year, this 2,000 cell is not enough. That's why we give 3,000 international units once a day for 90 days. Or again 60,000 international units. Here, 60,000 cells should be given twice in a month for 5 doses. Okay. In case this child had a symptomatic hypocalcemia, including seizures and all, first correct that part with IV calcium gluconate at 1 to 2 ml per kg, not milligram, it is ml per kg. And then give the maintenance treatment as per us. But in case it is a non-nutritional or refractory rickets as the causes, and we saw the tablet column, if it is hypophosphatemic part alone, or everything else is okay, you have to give an oral phosphorus of 35 to 75 milligram per kg per day with the oral calcitriol at 20 to 40 nanogram per kg per day. Okay, calcitriol is different from the vitamin D3 polycalciferol we are giving. That is international units. This is nanograms. In case it is vitamin D dependent rickets type 1, where 1 alpha hydroxylase problem is there, you'll have to give calcitriol itself as 150 to 200 nanogram per kg per day with oral calcium at 30 to 75 milligram per kg per day. For the type 2 one, where the receptor problem is there, still you have to give even more higher doses, 1 to 6 microgram. Till here it is nanogram, here it is microgram per day with IV calcium or high dose calcium 150 to 200 milligram per kg per day. Amongst all this, which is the best option? Prevention. Of course, if they come, you should treat, but prevention is something we should keep on telling. So when you go meet school children by talking this, that, and all, please tell them the importance of sunlight. Please emphasize parents on the importance of sunlight and recommended exposure as per the Indian Academy of Pediatrics. For infants itself, it is 15 to 15 to 30 minutes of sunlight, and older children 30 to 45 minutes of sunlight. So hereafter, if your children are having PT classes in the sun during this that time and all, yes, take necessary precautions if they are not well, this, that, and all, but otherwise let them get a little bit of sunlight. The ideal time is 11 a.m. to 3 p.m. Frequency 5 times a week. So the normal school days itself is well and good. And you see, it is not that you're supposed to stand in the sun without any clothing, this, that, and all, only then vitamin D will get. And exposure, which is recommended, is only 15 to 40% of the body surface area. So whichever part of it which is not clothed by the normal dress, if the shorts, that is skirt, the frock, the remaining part which is open only, that is more than enough to get the required vitamin D. So finally, concluding, let us emphasize on the proper usage of proper sunlight and proper dietary for vitamin D so that we can prevent rickets. And I hope you can also understand how to manage rickets, nutrition and refractive cases. So, thank you all.